Hi, everyone. Welcome. We are going to take a few minutes and then get started. Welcome, everyone. We'll get started in about 1 minute. Okay, welcome, everybody. My name is Martha Scarborough, and I am the Regional Resource Director in Georgia and Arizona for Caron Treatment Centers. Thank you so much for joining us today for our webinar on substance abuse in older adults, the hidden epidemic. And as a reminder, we will be conducting this session in webinar format, which means all participant microphones are going to be muted. So we will not be able to see or hear you. And during the presentation, you are welcome to utilize the Q&A or chat features to ask any questions. And depending on the volume of questions, if we can't get to your question today before the end of the hour, we will have someone from our team follow up with you directly. And today's presentation is eligible for 1 continuing education credit. And we would like to thank our educational partner, CE Learning Systems, for assisting and providing these credits through co-sponsorship with the American Psychological Association. You must remain on the presentation for the duration of the webinar in order to be eligible for your credit. And please note that in order to receive your credits, you will have to complete the post-webinar eval, and a link will be emailed to you directly after the presentation from cego.com. After finishing the eval, you will have immediate access to your certificate of completion. Today, I'm very proud to introduce our presenter, Sharon Matthew. She is our clinical director of our older adult program in Pennsylvania. She has worked at Caron for over 25 years. She developed and supervised the women's extended care program at Caron for 15 years and was also a very important part of developing the older adult program, which began in 2015. Sharon also developed the extended care family program and is a treatment provider for our chronic pain program. She has a master's degree in psychology. She's a licensed professional counselor, an advanced certified relapse prevention specialist, a certified clinical supervisor, a certified sex addiction therapist, and a certified multiple addictions therapist. And with that, I am happy to welcome Sharon Matthew. Thanks so much for being here today, Sharon. I'll turn it over to you.
Thank you so much, Martha, to you and your team for setting this up. It's always my pleasure to get the word out about what we've been doing here and also the need across the United States, across the country, actually, of this really damaging, and when they call it an invisible epidemic, it absolutely is, because it's not recognizable early on. So Today, my hope is to enlighten you about this fast-growing population, understand the treatment components. We've actually found what really works for older adults in a very integrated approach. And then, since the time limit is a little short, what we will do is just make sure that you have available the information for families as well, which the family is the patient. So we want everybody to understand the different dynamics that go along with treating an older adult and their family members. So that's our hope. And when we started this discussion about older adults, it was at the end of actually 2014. And we got a team of experts together, and we realized that more and more older adults were coming into treatment, and our logistics here is not conducive to treating older adults. So the terrain is difficult. So we found that having them together would be a better option with the specific treatment components for older adults. So I want people to understand that there is such a difference in the fragility of the older adult. As people age, you have the normal aging process, but then if you add a chemical or a substance or an addiction to it, it really changes everything. So the course of treatment has to be slow. It has to very much have a high medical component. We are blessed to have medical available to us 24/7. We are on the second floor of the medical center, and the first floor is all the docs. So that's what makes it very safe here for treating an older adult. And then you also have to look at, is this resistance? Is this pure resistance? I don't want anything to do with it. Are they absolutely unable to keep up, or that type of thing? So that's a slow process for us. So by 2050, they anticipate that the Americans age 65 and older will be at least 89 million people. And it also doubles the amount of older adults that were in the United States in 2010. So there, again, is the growing need for more capability of treating older adults. So, of course, the baby boomers, that expanded as well. So the World War II baby boomers, post-World War options that they had, and that type of thing. I'll talk about the generational piece in a minute. Okay. And in 1992, the number of Americans over 50 admitted to treatment centers was quite low. That was 6.6% of all admissions nationwide. By 2008, the number of admissions was 12%. And now in older adults, I'm very proud to say we've treated 700 older adults since 2015. We started in a 10-bed unit, and now we have a 15-bed unit, and we were almost always full. So there again shows the need for older adult treatment. People are coming into treatment more readily now. Statistically, alcohol has always been the #1 drug of choice for people 55 and older. And just so I can say this now, we started our unit with 65 and older, and that actually was too old. We had to lower our age limit to 55, and sometimes we even treat people younger if they are compromised medically or cognitively from the illness. So at this point, we're saying 55 and older. However, older adults are also certainly abusing illicit drugs. They are using opiates, of course. Sometimes they are using heroin or cocaine and marijuana. Older adults think they can use marijuana because they might have a marijuana card. They use more legal prescriptions than any other population. And then also a second to alcohol, benzodiazepines and opiates are oftentimes prescribed for chronic pain, and benzos are also given because of anxiety, inability to sleep, life changes, and that type of thing. We are seeing that there's more and more benzos being used now than even opiates for this population, and difficult definitely to get off of the benzos. So how is the industry reacting? Within the next several years, there's going to be more boomers and seniors in America than children. They are living longer and also with more complicated multiple chronic disorders, other than the disease of addiction. And for the next 18 years, older adults will be turning 65 at a rate of 8,000 to 10,000 a day. So there are 55 million older adults in the United States, and about 4.4 million of those need substance use treatment. And we are one of the few places who can treat that population, who have learned, I call it the secret sauce of how to do that population. And there's going to be more and more people geared to giving that type of treatment based on those numbers. Healthcare costs went through the roof, $100 billion by 2018. Again, most commonly abused painkillers are hydrocodone, oxycodone, oxycontin. That went up 50%. So narcotics are being supplied. There's the 15% mark from 2007 to 2012. I know that's gone up and it's higher now. 43 million seniors getting Medicare prescriptions. 1 out of 5 are using those for possibly opiates, narcotics. 1/3 of the prescription drugs in the United States are given to older adults, and 2/3 of the over-the-counter medications are purchased by older adults. So there's the complication, which I'll talk to you about in a minute, of how this goes undetected, how nobody knows. And sometimes you don't know what they're using. So they might have been prescribed something by a doctor. And this is a population also that follows the men in the white coats. So if the doctor prescribed it, it must be okay for me. And they actually believe that until other things enter in. So I think I do want to talk a second about the generational differences, which actually plays into how we do treatment. So 25 to 45 is the silent generation. They had less education. They valued and protected their finances. They didn't overspend. They had more children. They had less disposable income and more religiosity. So that makes them a little more tight on the aspect of sharing and not wanting to. They also want to protect their families. I think this is what I see with the older generation too. They want to make sure that there's something there for their kids. And sometimes they actually lack spending money on themselves for that reason. And then we have the baby boomer generation, higher education, willing to take on more debt, fewer kids, more disposable income, and less religiosity. What we're seeing, and I think I have slides later on about boomers, that was the time of sex, drugs, and rock and roll. And so sometimes that gives them those permission-giving thoughts of, well, it was okay for me then, back in college, it was no problem. And that also feeds into maybe why they continue their use later on or return to it maybe after retirement. And then this is Generation X is 66 to 71. Then there was legalized abortion, invention of birth control pill. There were more divorces. There were absent fathers and working mothers. Latchkey kids, risk takers, fewer kids, both people working, busy with their lives, maybe not having as much time for their kids. So that plays into how they act or react as an older adult, or later on in life, I should say. So treating older adults in a successful way, we have found that, at Caron, we have an integrated model. Everything's interdisciplinary, and older adults really, really is to the nth degree. Physically, it has to come first. Physically, they have to be safe. Emotionally, most people have some other co-occurring issues such as depression or anxiety, and have been medicating with whatever it might be. It could have been alcohol or a pill that a doctor prescribed. Spiritually, many are so detached from their spiritual aspect because of being sort of hiding out with a chemical, not being available to seek what would make them feel better. Medically, they absolutely need all the attention, and recreationally, they need to get up and moving. We believe that motion is lotion. So we do get them moving every day with a wellness consult. They come over and they do chair yoga or mild things that they can do in their small area. Nutritionally, they are all seen by the nutritionist because most have been deconditioned. They have been sometimes drinking their calories so that they don't nourish themselves with the good foods. Socially and systemically, many of them socially were isolated and so pulled away and didn't have that outreach with other folks that they can relate to. And then systemically, of course, the caregivers are extremely affected and they also need attention in a good way. This is a population that demands respect and a non-confrontational approach. I've worked in treatment setting for 28 years, 25 years at Caron, and I treated 19-year-olds to like 72-year-olds. But when we had the young ones, I could confront them about their behaviors or even their denial, and they would actually be okay with it. This population will not have that. You have to do it in a much gentler and subtle kind of way. So let's look at the vulnerability. Older adults are absolutely more vulnerable to the effects of alcohol. And I know later on I mentioned that they do not metabolize the substances as they did when they were younger. Definitely increased risk for comorbid diseases. We see so many people who have heart trouble, who have diabetes, who have chronic pain conditions. And it causes such a mixed bag of what do you look at first, but what we know is we have to do it at the same time and equally alongside of each other. Increased risk for harmful drug interaction. As I said before, sometimes nobody knows how much they were using or maybe what they were using due to some of the cognitive issues they might have. Many people come to us because they have fallen, so we see an increased risk of them falling and maybe having a hospital stay before they even get to us, possibly going into withdrawal if they're not attended to. There is definitely depression and anxiety, liver issues, cardiovascular diseases, as I mentioned. So there's the fall risk. Some people come to us with black eyes, broken bones, broken shoulder, the cuff, rotator cuffs, internal bleeding or head injuries. Many people come in with a traumatic brain injury as a result of falling as they were under the influence. Poor cognition interferes with the ability to recall their use history. So what I tell my clinicians, start gradually and slowly, and in time you might get more, but you can't expect to do a full history and get all of the information early on. That just does not work. Oftentimes they do not remember. Oftentimes they were they could have been in a blackout, but they just don't remember, and oftentimes it's because of cognitive issues. Withdrawal management challenges. I work with an excellent expert, Dr. Wang, who is now our medical director, and he absolutely knows how to safely withdraw based on all these other complicated factors. So I don't want to spend too much time on this, but at-risk drinking. So as Dr. Wang always said, later on in life, it doesn't matter how much you're drinking or how often, it affects you differently than it did when you were younger. So oftentimes people will say, but I only had 2 drinks a day. I only this and that and the other thing. That doesn't matter anymore because it's not serving you well and your body is reacting to it differently. And these are the things that I have listed here, stressors that affect someone in older age. Retirement. So many of our people were successful and are now retired. So there you have too much time on your hands. Not as much income, so they're worried about their families ongoingly. Some have lost a partner or a wife or spouse or a husband who they were married to for 40 some years, 50 some years. That is a tremendous loss for this population. They do not know what to do with themselves, and they're oftentimes lonely. Their families might live all over the place, and then they're lost and certainly alone. There's another statistic for you about talking about heavy drinkers versus binge drinkers. At this point, as I said, it really doesn't matter how much or how little you were drinking. It doesn't sit well with the older adult person. And oftentimes it goes undetected. So unfortunately, it could be going to a doctor, they could be going to a specialist, but most likely they will minimize and deny that they're drinking too much or taking extra pills. And we actually have people who will take more than prescribed as a direct result of their cognitive issues. Fewer older adults, it says, seek help. And I guess I have to challenge that a little bit. They would not seek help on their own. However, here we have family members. Family members are usually the persons who say, I can't do this anymore. I'm really worried about you. So that could be a spouse, that could be an adult child or a sibling. And this population oftentimes comes in because they've hired an interventionist. This is not a population who will necessarily hear you say that they are not doing well with their drinking or their addiction. And it does take time, and there's ways to do that. So again, those similar statistics to what I gave you before, so I won't spend time on that, because I think what I'd love for you to see is how it complicates their lives. So these are the signs and symptoms that are complicated by addiction. They absolutely have sleep problems. They will say, I'm taking benzos because I can't sleep. I have to take some drinks at night, or I have to get up in the middle of the night to take a few more drinks because I can't sleep. Health complications in many ways, decline in their activities, daily living. You will see them doing less. You will see sometimes their homes are disheveled. That's oftentimes how an adult child or someone who doesn't see them often would understand that something's going on here. Unexplained bruises, for sure. They are absolutely fall risks. What happens as a person ages, the equilibrium is already sometimes compromised. Well, you add a chemical to that, and that is even more problematic. complication in their medication. So if they're maintained on a medication, how do we know that the alcohol or the addictive substance isn't interfering in the ability for that to work? So if they're on an antidepressant, it cannot work if they are using an addictive substance. We look at the disease concept, chronic, progressive, characterized by denial. It's the only way it really keeps going. As we've mentioned, or I've mentioned, extremely vulnerable this population is. Memory loss, dementia, and delirium. So there's the complicated little ball of wax there. Do they have memory loss as a direct result of aging? Is it because of their chemical use, or is it the starts of dementia? And that really needs to be teased out. We cannot early on diagnose that at all. We have to get them off the chemicals for several weeks before our psychologist, Dr. Daughtry, can get a clear picture of that. So here we start with the Montreal cognitive screen, and 30 is normal, 26, under 26 is starting to be impaired. I will tell you some numbers in a bit, because what we're seeing is more compromised than ever as a result of a few things. As I mentioned, people are malnutritioned, incontinence happens, lack of social interaction. They are isolating in their homes, not reaching out, not answering their phones. Vision problems, definitely hearing problems. We have so many right now who are hearing impaired as a result of their use. There's cognitive decline, as I mentioned, and oftentimes impotence as well. This is the parts of the body that Dr. Wang always says it affects every part of the body. When you are using addictive substance, central nervous system, the cardiovascular system, your lungs, your musculoskeletal, the renal system, and the gastrointestinal. So many people have stomach problems. And then they try to medicate on their own, that over-the-counter medication thing I talked about. Oftentimes they're trying to fix that on their own, not realizing that the chemicals they're using are causing harm. So I put this in here because, those first slides are very heavy. They're very sort of depressing, to say the least. And sometimes I actually tell my patients that they don't have to live like that. What we're trying to do is get purpose and quality of life back to them. So Sylvester, if you all know Sylvester, which I'm sure you do, he is now 75. And he is considered what we call a superager. I do a whole other thing on superaging if you ever want to hear that. But superagers, it was a study done by Harvard, and superagers are either physically or cognitively 15 years younger than their chronological age as a result of taking care of themselves. So he is one of them. And then Edith Connor, she is a bodybuilder who still is doing bodybuilding, and she is 86. In no shape or form could they be this if they had been using addictive substances. So I just show this to them that it can turn around, and it can turn around later on in life. You're never done growing or changing. So in order to get to be that, the treatment components that we found that really, really work are this. The environment has to be small, safe, and self-contained. So as I said, we have the whole second floor of the medical center. Everything is delivered to them. We have groups on the lower level. The doctors in physical therapy and the acupuncturist are on the first floor, dining services first floor. And then we deliver other treatments on the second floor. So, and we are, as I said, the only ones who have nursing 24/7. Geriatric specialists, we've all gotten some really good training when we first, or even before we started to open, when we were doing our project management around how to do this. We consulted with a local residential setting for older adults near us here in Warrensville, Pennsylvania. And we also used Dr. Krantz, who is our medical director in Florida. She had worked for Hanley, and Hanley was at that point the only older adult setting that really was good in treating older adults with addiction issues. So we consulted with all those, we trained everybody, and everybody has to have an understanding of what it's like to treat older adults. It is, I say to people all the time, not for the faint of heart. Do you repeat yourself over and over because of cognitive issues? Absolutely. Do you have to meet them where they are? Absolutely. And then what I found is you have to be really creative, because you cannot just stand there and lecture, hoping that it will sink in. Spiritual counseling, very necessary. This is a population who has either detached themselves from either religion or spirituality. This is a population who has tremendous grief and loss that they didn't look at or didn't realize they had, whether it be the loss of a job, loss of time, loss of mobility, or loss of a person. And so we have an excellent spiritual counselor, Meredith, Dr. Hardy, who meets with them. And we do go back to their family of origin. This is a population also who has ignored and postponed and not looked at any kind of trauma they've had since they were young people. And it's so sad to see them carry this baggage, and it is baggage, around for all their years. They get busy with their lives, they get busy with their families or a profession and a job. And then once they don't have that, what happens is there they are with themselves. And oftentimes that is the fuel for the fire that gets them to medicate themselves. So we do in-depth work around family of origin. We do in-depth work. We also have a trauma program now, a trauma informed program where I have a clinician who's trained in doing the groups. I have another clinician who's trained in trauma expressive art. This is a population that loves experiential work, so oftentimes I will bring that into my groups. They like to see it. They like to see what it looks like and sounds like. Patient-centered for sure. As I said, the nutritionist sees them as needed. We get them out to eye doctors, hearing specialists. If they have ambulation issues, oftentimes people will come here in a wheelchair or a walker. Eventually they move up to a cane and then they're good to go. It's so wonderful to see. And that is exactly why we have a 6-week length of stay. Somebody said to me, I've never heard of a rehab having a 6-week length of stay. Older adults need a 6-week length of stay. It takes that long because they're a little bit slow out of the gate at the beginning. The cognitive impairment, I cannot stress enough, and we've seen an increase in that, and I know COVID played into that, and I think I have a slide here about what COVID did to impact our older adults. Fall risk I mentioned, so we have to be very careful. We put a fall risk alert in their charts, and they wear a band to know that they can't waltz around the grounds here by themselves, and they also don't go to the gym until they're cleared. I think the clinicians absolutely have to be very much more skilled. I think they need more tricks for sure. We do DBT, dialectical behavioral therapy. They absolutely loved the Life Worth Living lecture that I give because that does talk about quality and purpose of life, which is what they all need as far as having hope. I do radical acceptance. That's another one that really resonates well with them because at this stage in the game, what choice do we have except to radically accept this is how it is, this is where it's come to, and what am I going to do moving forward? Complicated grief I talked about. Stages of treatment, do they like groups or versus individuals? They will definitely more readily talk about the heavy duty things in individual sessions. This is not a group that airs their dirty laundry or wants to basically talk meanly or badly, if they would put it that way, about their family of origin. We do family of origin group, but very general group of what messages to get to, from your family. And then we do impact letters. So impact letters is a really good way of breaking through denial. So the family members will write an impact letter. It just says your addiction has affected me most by, boom, boom, and then they share the ins and outs of that and give them, hope. And yes, I would love to reconnect it with you in a good, healthy way, but I can no longer go on this way. That oftentimes does give them motivation. Just talked to a gentleman today that doesn't believe in the disease, which is fine. And I told him at this point, it really doesn't matter, but your body's not faring very well. You've wound up in the hospital before you got here. And your family is extremely worried about you. And all they want is for you to be back with them. And so at this point, I don't care what gets them to the chairs. I don't care what gets them moving and going. Let it be the family for now. Let it be the health problems. Eventually, what we see is oftentimes they do want to be better, feel better, and it gives them internal motivation. We do 12-step recovery, but we don't force them into that. Many people don't want the 12-step AA regular kind of meeting, so we do offer smart recovery here. We do Dharma for those who believe in the Buddhist philosophy. So there's other ways to embrace that with them. Mindfulness we practice as well. And then upon discharge, which I'll go into that a little bit later, is a very detailed recovery plan because it's so very varied. It is not cookie cutter. It can't be one size fits all. It has to be individualized to their needs and how much they've grown and what they need going further. So there's the purpose and quality of life, which is our motto. So I gave this as an example. This was done some time ago, but we do family trees. It's very interesting if they can comprehend the concept of this was grandma and this is what they were like. With older adults, you don't get as much information, but you get necessary information. So this is just an example of what a family tree looks like when you look at and trace the addictions, codependency, mental health, eating disorders, any of that, and if people were also in recovery. And then this is an example of mask work we do. We just did a whole group around that. That's the props that are sitting behind me right now. So they do a mask about what they present to the outside world and then what they hide beneath it, and then they write a little paragraph about it. It is a very powerful exercise, and as simple as some of them are, very impactful because the insides are usually filled with sadness, a lot of shame, a lot of guilt, and if they've had trauma, you also see a lot of darkness. So I really love doing the mask exercise because what we want is for their insides to match their outside. Also, when I mentioned the family of origin work, the way we talk to our children becomes our inner voice, absolutely. So if you see the cheerleader on the right, the family that says, you can do it, you know, you're good at everything, you're the best, you're the star, awesome job, and they give them all that positive feedback. Well, on the other side of those negative messages, you're an idiot, shut up, go away, you're never going to amount to anything. Always putting someone down. If they got an A minus, why wasn't that an A? If they got a B, why wasn't that an A plus? You know, always putting them down. This is so strong in this older population. I can't express that enough. We just did a family of origin yesterday, and I just dealt with a client who just moved on. And his message was always that he will never be good enough, never be good enough. His dad was an alcoholic, mother was an alcoholic. And that message stayed with him, even though he became extremely successful. But even to the point of getting to the door here at Caron, he still had that message. And we worked on that the entire time he was here. Because those messages must come, you must come to terms with them and move forward, or it will always, always pull you down. So here's a little bit about the boomers. I did another PowerPoint on just boomers, and it's really interesting how they act and react. So it is the age of sex, drugs, and rock and roll. They often see it as drugs a way to either get comfortable in our own skin or to combat loneliness or depression. I had a patient here who was a true boomer, smoked pot in college, cocaine as well, became a musician, then got busy and had a steady job in the tech world. And he came to us when he was then, I think, 72. And he got back to playing the piano here. And we got him to understand because he wanted to go back to continue his pot smoking. And we told him that would not be a good idea for many reasons. And he finally embraced it. And he did go home. And, well, he actually went to sober living. So this is the key. We do use sober living for older adults. If anybody knows of any that caters to older adults, more resources for us would be best. Finding one for women is almost impossible. Finding some for men is a little easier. But he went to sober living. He went home and stayed sober and just contacted us a couple months ago that his life is good. Extended periods of isolation happens for this population. Also, like when they have no purpose anymore. So the kids are out of the house. The kids now have their own kids and they're busy with their lives. Then what happens to the older adult if you don't have that interaction with others? Some were what we call hardcore drug users, and they're even at a higher risk to have more physical problems later on in life. That statistic is scary. 2013, more than 13,000 boomers died from an accidental drug overdose. And there again, they seem to use more chemicals. And again, the body doesn't metabolize it, so it doesn't break down. And that's why it has a greater effect on them. So this is the slide I used for my, I think it was my SuperAging. Substance abuse overlooked, absolutely. Ageism can cause some people to stay silent about it. Well, we can't confront, right there's grandma. We can't confront grandma, or we can't confront mom, or we can't confront dad. He was the dad of the family. He's the one that raised us. He was the patriarch of the family, so we stay silent, don't say anything. They have a different set of standard for young people. We shove younger people off to treatment. They're smoking a little pot, let's get them to treatment. This got to stop right now. Whereas with an older adult, it'll be ignored. We've treated 90-year-olds, and someone actually said to me, well, why bother? They're 90 years old. Well, why not bother? Because they're not living purpose and quality of life. At 90 years old, these two would have been very physically fit. and yet they were drinking and their houses were disheveled and they were isolating. So why not come into treatment? So it becomes acceptable to ignore addiction in a baby boomer, which is very sad to say. There's a statement, just let them drink. They're older anyway. And grandma needs her happy juice because it's easy to manage. So there are some crabby, and I call them curmudgeons, older adults. If they were not happy when they were younger, they're certainly not going to be happy as an older adult. And that's because I believe they haven't come to terms, or that's how they were raised. But that's not the answer. It is not the answer, because there can be joy later on. The same disorder that would affect the family, rallying around and staging intervention for a teenager sometimes doesn't elicit that urgency in a grandparent or an old adult until it's absolutely the only answer. We have several people here right now who came in as a result of a DUI, as a result of the family intervention. You better get treatment or you're not going to be in the house. I don't, again, care what gets them to the chairs, just so they get here. So needless to say, the older adults are, I would say complex should be first. Complex, very diverse, ever-changing, clinically challenging for sure, unique folks, and rewarding to serve. That, I think, in all of my career, especially here at Caron, this is a population you can literally see them come back to health. And it's awesome to watch them physically. You can show them their picture when they arrive and then show it later on, and it really means something to them. They'll say to you oftentimes, I don't ever want to be back there again. So that again shows motivation to get better. So I do believe, and it's never too late to develop an addiction. So some people ask, I saw some of the questions. I tell people all the time, some people were not addicted or showing addiction traits early on. However, later on, they became physically and psychologically dependent on a chemical. That happens a lot with chronic pain people. That happens a lot with people who were using opiates. So it doesn't mean that it wasn't maybe sitting there, but I tell them, so maybe you didn't have it then, but right now, this is where you are today. You have developed a dependency on the chemical. You overuse, your life is unmanageable. So that's where you have to go. And again, interventionists for older adults are very helpful to the family. And I do believe it's never too late to have quality of life. So my slide, I don't think was in there about COVID. Did you see his COVID slide? Okay. So I think I can remember what I had written about this. So during COVID, we saw an increase, of course, in relapse for people that had recovery. And the excuse was, I hate Zoom meetings. I'm sick of those Zoom meetings. It's very impersonal. I can't get out of the house. So that was the excuse to use. During COVID also, they used more of any substance. And then they also were drinking like earlier in the day to fill in their hours. So now that they're coming into treatment, it's so sad to see not only the physical complications, but also the cognitive. I think that's where it's hitting them even more so. So right now we have several, and as I told you the score of the Montreal score, 30 normal, 26 and under compared. Right now I have an 18 score, I have a 16 score, and I have a 14 score. That is extremely impaired. Will they get it back? Hopefully so. So what we do is Dr. Daughtry will, in 3 weeks, retest them. If you see the number bounce back, then that's really good news. That means that they could be healing and getting better, and there's a better chance they don't have dementia. If it stays at a stuck point, which we've had people who scored, I had this lovely couple, and we do treat couples, let me say that as well. What a better way to come to treatment if you have 2 addicts or alcoholics in the family, bring them in at the same time. And we have learned how to do that really well. But we had a wife who scored 2. We had a husband who scored 14. Very sad because she did not change and she did have the starts of dementia. And then his came up 1 point, which was not significant. So we did, in that case, get them to assisted living with the help of the family, and there was memory care attached right to it. So that's where I talk about the length, the different levels of care after are so varied. Some will go home. Some will need a caregiver in the home other than the family member. Some will need a recovery coach. Recovery coaches work really, really well for this population. Recovery coaches can guide them in the early days and get them to the first meeting because they're not so familiar. They're doing meetings here and they're doing speaker meetings and that type of thing, but going to the one in the outside world is a lot more difficult for them. And then sober living, as I mentioned. If it is assisted living or that type of thing, we can guide the family, but we cannot set it up because we are not in charge of their finances. We really hope that family members, before they get here, will have power of attorney financially and medically so that they can have an easier way to do this. So in that couple that I talked about, family did awesome. They researched someplace that would be closer to where they had been living. We toured them via Zoom here so they could see the apartment they were going to. And they both went off to assisted living with memory care attached because we knew she'd have to enter that sooner than the husband. So that was a really good result in that case. So that's some of the aftercare, and that takes quite a while to set up. So it's not just a week, oh, let's get this together. So it's something we talk about for probably the last 3 weeks of treatment. So let me just check what we have here. I will go through some of these slides. Is the population going to get, is the audience going to be able to get the slides? You can answer that, Julie. Yes. So as we know, you have to take your oxygen first. If you are not breathing, how can you help anybody? So that's why I have that first slide there from Jamie Heisman. So caregivers, oh my goodness, I don't even know where to start. I'm actually doing a PowerPoint on denial with my family therapist who works for me, Dan. So we're going to do denial around the older adult population because it's a lot different than the younger population, and denial around that for the family members as well, who become the caregivers. So they are absolutely usually on the burnout point by the time we get the patient, and it oftentimes fuels their own use. They might join them, they might drink with them, they might be taking benzodiazepines as well, chronically exhausted. Some are actually still working. Some of my older adult spouses are still working, so it interferes in their day-to-day lives. They become ineffective at work, and their values, they're covering up, they're not telling the truth. So as we know, we used to use the term, codependency is still a term, and people become dependent in this dysfunctional way and cover up for the things that are going on that are not going well. And over time, it is an absolute downward spiral. So caregivers are not only busy with their own lives, but they're giving to this person who needs care. It takes a real toll on the body, the mind, the emotions. They also might have role confusion. Well, who am I today? I'm supposed to be this, and I'm doing this, and I'm doing this, taking care of the house, and I'm taking care of this person. So they get very confused. But then the kicker is when we get these folks, unrealistic expectations. So they absolutely want us to fix their loved one. This is something we cannot do. We can guide them, we can coach them, we can move them forward, we can get them physically better. The outcome of that, we have no control of. And oftentimes what we'll see is the family members are so scared in the beginning, they're calling you 5 times a day wanting updates, even though they're so upset with the patient. But then at the end, they're doing the same thing because they know they're coming back to them most likely. And then they're off the hook again. So that's why we really need family members also to get their own therapy. And we oftentimes see caregivers passing on before the older adult. So here's what caregiving impacts. So there's a sandwich generation where you have an older adult and you have the adult child here and then maybe their adult child. So that's the sandwich generation, all living under one household sometimes. Then the club sandwich is the older adult, then their child, and then their child, and then a grandchild. We see that oftentimes. That sounds so heavy to me, and I've been in that role where I was there for my kid and his kids at one point in college, working a full-time job. It's very heavy, and how we stay well, I don't know, but self-care has to happen somehow. Availability of medications, and then having that baby boomer mindset, possibly. Absolutely anxious, depressed, scared, and then they try to be the end-all be-all for the patient, which cannot happen. I don't care if it's an older adult, younger adult, family members cannot replace that and be that for their patient. This slide I find very helpful because if you're in a caretaking role or in a codependent spiral, which is what this is, you start over here in the left, and things aren't going well, you feel underappreciated, you get angry in that top triangle, the red triangle. You lash out at others, this isn't going right, look at all I'm doing for you. And then because it's not going well, guess what? You have feelings of guilt, shame. and saying if I was a better person or if I could do everything at once and be that miracle worker, everything would go fine. And then silence, then we get silent. I was this in my codependency, I'm a recovering codependent. We get silent and we disengage. And then if there's kids around, they're going to think it's their fault. So then they become little caregivers and caretakers at a very young age. We try to keep the ball going and we do it for others. And that spiral goes on. And then we feel unappreciated all over again. It is very heavy. That slide makes me tired just thinking about it. And what we need to do is detach that loved one from that spiral. So families are usually referent. They are scared, tired. They absolutely don't know what to do. They don't have the words. They don't know what to say. And they're fearful of confronting the issues. And what we found with the family members, oftentimes they've had their own family of origin issues, which plays into this. Oftentimes they came from an alcoholic system, and then they're married to this person for X amount of years and saying, oh my God, now what am I going to do? And then they relive that all over again. So they need education. We do signature family program is my family therapist and another family therapist in Grandview, the group for professionals, and they will meet with the families one time for treatment experience on a Monday every 2 weeks, and they will educate them about the disease. They will show them films. They will have them look at PowerPoints, and then they can interact with them on that webinar. Talking definitely about boundaries, because you have to have a conversation such as, your addiction isn't welcome in the home anymore. I have a gentleman right now, he has nothing between him and the next drink because he is cognitively impaired. He is here for his family. That is okay. Now, they won't be able to keep him sober, but as long as he understands that if you don't stay sober, we won't be around, that will keep him going. And then families, absolutely, because I always end my sessions, well, what are you doing for you? And then they stammer, well, I'm doing this, but it had nothing to do with wellness or being sober or being well, period. So getting them to accept that is a different story. So that's some of the types of continuing care. We do educate the family about that. We have to have their buy-in for it, no matter what it is, whether it be an extended care somewhere, outpatient, caregivers in the home, getting them to meetings, wraparound services. As I said, recovery coaches are awesome for this population. And then because of all that, and because of the family involvement, there is a high risk of success with older adults because they do not want to disappoint. I have a person right now whose daughter said, if you do not get sober, you will not be with your grandchildren. And she absolutely means it. So for now, she took a step back. She is working on her anger. And I always tell people they want to see your actions, not your lip service. They have to see from you that you're willing to do some changing. So since we're not live, I can't sculpt the daily program, but a daily program would be all those factors I talked about, spiritually, medically, physically, socially, and emotionally. So a crisis, gets us to change. It is an opportunity. Most of the people we get here came in as a result of a crisis, whether it be hospitalization, the falls I talked about, or families just not being able to watch them on the downward spiral any longer. So that's what gets them here. So I do believe that's it. And I look forward to answering any questions if I can, if I haven't answered them in my PowerPoint. So I want to turn this over to Martha.
Thanks, Sharon. That was a great presentation. You guys are really doing some special work. We have some really good questions. And just as a reminder, if we don't get to yours, we will follow up with everyone. So the first question that I have is, do you know of a training regarding how to approach leading an individual to radical acceptance?
Well, just DBT. If you do the DBT work, and I will say, we do DBT Consults. There's a DBT work group that came along when you get trained in DBT. We do a work group once a month. And that means we are looking at ourselves as to how we're functioning with the patients. It looks at your struggles. It looks at the team's struggles. What are our stuck points? What is our countertransference and all of that? So throughout that, I think we all here have really learned how to practice that on a daily basis. So I would say any kind of DBT trainings you could attend, or, even the long version. We all had a mini version, and then there's one expert here. Jenna Wolf is the DBT expert. She does an awesome job. So look for anything of that nature. And if you look through the manual, that radical acceptance has good worksheets as to how to get them to embrace it.
Great. Thanks, Sharon. Is the process of getting older adults to commit to treatment different than younger patients?
Yes, and I think I mentioned the reasons, sometimes it's ego, sometimes it's stubbornness, sometimes it's immense denial. The denial lays so differently in this older population. I think there's more leverage off times with a younger person, and they're going to come back and say, hey, listen, I supported you. I was here. I'm the breadwinner. Who are you to tell me? So it is also that level of how can I tell dad? So it has to be done, first of all, very gently. They have to have all their little ducks in a row, a family, before they talk to their loved one. And they all have to come together. And they have to be from the heart telling them, we really can't watch this anymore. You need to do something. And then that seems to work. So it's a little more difficult, but absolutely possible. But that's why they use interventionists to find the words.
Great. Is a 6-week length of stay standard, and do people sometimes stay longer?
Yes and yes. So 6 weeks we've found for older adults is absolutely needed, and oftentimes they do need more. So we've had variable length of stays early on. We had a woman stay 5 months. I had a guy who didn't want to be here, and he stayed and he stayed. He did 3 months. He's now sober 4 years. It was benzodiazepines for like 15 years, which is almost a possible thing to get off of. So yes, so it can be a varied. We do not, only if someone was going on, maybe they came back for a refresher and then they were going on to extended care or sober living, would be maybe make it shorter. But usually their health requirement means longer, not less.
Makes sense. Do you know some of the telltale signs of wet brain?
Well, early on, we had a woman who we were told most likely she had Korsakoff's. So I've seen it personally with her, and I've seen it when I worked in the detox unit, where every time you talk to them, they have a different birthday. Every time you talk to them, they have no recollection of whatever happened. So it's long-term and short-term. So with this woman, she also had a thiamine deficiency. So she came from your area, Martha, and I can remember really well. We kept her, I think, a little bit longer than 6 weeks, and then she went on to another one of our facilities because what she needed was time. Did she get a little bit better? Yes, without the drinking and with extra thiamine. Yes, she did, but it was not going to be a drastic change. You know what I mean? So those kind of folks we know should never be going back and living alone. Those kind of folks should be going someplace that has memory care. When we see, like the people I'm talking about right now, the guy that scored 14, he thinks this is where the denial, he thinks he's good. He thinks he has no issues. Oh yeah, I forgot that a little bit, but so they have long-term memory. They can go back to that, but they do not have somebody described it to me at the Alzheimer's conference where you have a file cabinet, and if you can't put new files into that, you probably know that you have the starts of dementia. So some of these folks, there's no files going back in.
So kind of on that note, Sharon, what do you do if you have an older adult patient and they're given a boundary, but they are so cognitively compromised that they really can't understand that boundary?
So them not understanding is possible, but not the biggest problem. So I have a gentleman right now, you think he was fine and he's not. And too much drinking, too many seizures, blah, blah. So the wife knows and was told he's going to need memory care. We describe it to him. He's the kind of guy that show me where to go and I'll go. So that's actually an easier sell than those who are so stubborn and stuck in there, But it's, again, the leverage of the family. I had a woman who absolutely was memory impaired, needed a memory unit, and the son stayed fast. He said, Mom, you are not going back to your house. He took charge. We got her to memory care, which is the right thing to do. Are they upset? You have to ride the tide of them being upset and go beyond it, because yes, they're going to be upset, but people with memory issues will adjust to where they are eventually when they get there. So you got to get the families on board with that.
Makes sense. Sharon, can you explain a little bit about the admissions process and what that looks like for this community? Like, Can it be quick? Does it take a long time?
It's long and tedious. I've never seen anything like it with the admissions folks. They work very hard on cases for weeks or even months. We have a guy, we've been working on this case for 3 months. He's finally coming in at the end of the month. It's almost like too good to be true. Takes a lot of conversations. So Dr. Wang and I are most happy to get on a phone call. We not only talk to the families, we talk to the prospective patients. We have done web access where we see them on the TV and we explain everything. They need reassurance. They're absolutely scared to come here. We do a lot of calls with family members. And then finally, I call it getting them on the hook. When we get them on the hook, it again goes back to the family. They've got to stay steady. This is what we're doing, and this is when we're doing it, and we're going to do it, or whatever. So I have people from California right now. The son doesn't even live near her, and he did his part, got her here to treatment, and she's here. But it takes time, lots more time. The others are a quick turnaround, like somebody will call one day and they're in maybe treatment the next. That doesn't usually happen for us.
Great. Okay, we're going to do one more, Sharon. How much are you seeing in terms of addiction to pain medication versus other drugs and also alcohol?
So as I mentioned, alcohol is still first, and people minimize alcohol is really ruining. It's a slower, unfortunate process of the demise, right? Pills, you can more readily see sometimes the damage. But what I want to say is what we're seeing, not only the marijuana, so we use it, they use drugs from the doctor and they add stuff to that. Recently, we have now had our third patient who's using whippets. Now think about that with an older adult. They are using whippets, and many of them. And had a guy from Philadelphia, he was a janitor, he would go to his closet and he'd get high. And what happens is they have neuropathy, they have no feeling in their feet, their legs, and all that. The one woman had horrible pain in her shoulders because it affects the nervous system. I had a young guy, he was 37, could not walk when he got here. He was using whippets. So they will use, we call it chemical coping, they will use whatever they can get their hands on. They'll use more of it. And that's why I think the mental health in this world, as we all know, has gone really down the drain. COVID really shone a light on it, is what I believe. I think people were already off the hook. And I think with COVID, it just put us over the edge. That's why outpatients are all full and booked. That's why more people are going into private practice, all of that. Because people are absolutely sicker in one way or another, and they're chemically coping with whatever they can get their hands on.
Well, thank you again, Sharon, for your presentation, and also to all of our attendees for joining us today. And just as a reminder, this presentation is eligible for 1 continuing education credit. So watch your email for a link from cego.com and complete your eval there. Before we close out, I just wanted to share an upcoming webinar that is available from Caron. So please save the date. Caron is hosting a webinar on Wednesday, December 1st from 12 p.m. to 1 p.m. And it's entitled Family Relapse When Patterns Re-Emerge, and registration is open. So we hope to see everyone at that virtual event as well. In the meantime, if anyone needs any information or any help, please reach out to your local regional resource director at any time for additional information. We're happy to help and provide resources in your area or answer any questions regarding admissions to Caron. So thanks for joining us, and I hope everyone has a wonderful afternoon.
You too. Thank you so much.
Thanks, Sharon.
Bye.